Hi guys, there's only three of us. Let's see how we do. Do you have any questions for me?
I want to start with the question when there is a special test and you ask so many times that's a specificity versus sensitivity. So how do we define whether it's more specific or more sensitive?
You get it. You get it from the research. They'll tell you.
Okay.
All right.
Like for example, you said 14 fingers. Is it 100% specific or is it sensitive?
14s. Yeah. No, it's sensitive more than specific. This is the specificity isn't known. Actually, the sensitivity is a bit up in the air as well. But because there wasn't a comparison to non-symptomatic people, that is a control group. There was no control group there. So it's difficult to actually talk about validity numbers when you don't have some form of control, either a matching control or a random control. So you really can't talk hard numbers on this. Okay. Specificity isn't known. Sensitivity is believed to be very, very high.
Okay.
But that's what it is. It's a belief that it's high, but you haven't got exact numbers on it.
Okay.
If you look at something like sharp Purser, this was done against a gold standard, and they had control and subject groups. So you get exact sensitivity and specificity numbers from that. But it's what Fortin did, it was Fortin and Falco, what he did was everybody who had symptoms that he thought were SI joint problems, he basically injected with two anesthetics, long and long-term, short-term anesthetics. And the ones who got better, he said, were SI joint problems, painful SI joint problems. And the ones who didn't get better with them, he said, weren't. And that was it. So the study wasn't terribly well done. I'm not sure that he was actually looking for sensitiveness, specificity. I just wanted to see if his idea of what would work did work, almost a pilot test. But I don't know that it was ever followed up on. Medicine's bad for that. Medicine is really bad for that. Replication studies are never done. Never do it, because you can't get them published. So it's somewhat less of a science because of a good bit less of a science because of that. So there you go.
I tried to look up the research on the 14s test.
Yeah.
And I forget where I found this, but it said 70% specific.
Yeah. Did they? Which study was that?
I have no idea.
My guess, yeah, I haven't seen one that's been done since then, to be honest with you. I don't know why not, to be honest. I really don't understand why not.
Like, why not 100%, do you mean?
Why they're not doing them.
Oh, I see.
And the probability is that's a guess, and it's probably not a bad guess. And it's probably based more on clinical experience. My experience is exactly what they're saying. If you have a symptomatic SI joint problem, then Fortin's test is likely to be positive, very likely to be positive. On the other hand, it's not very likely to be specific because the back could do that as well. So it'd be nice if it was 70% sensitive and say 95% sensitive and 70% specific. But I don't think this research is done well at all. If you look at the published stuff on research, this was done quite a while back in Spine now, but they looked at all of the studies and they found one journal, it was orthopedic and related research, only 5% of the studies they published reached reasonable rigor, scientific rigor, 5%. And that, I think Spine did the best, which is why they published it, and they were around about 60%. So these are really bad really bad studies, really. They were publishing stuff that if it was going to be published, they should have put something on it saying this is not up to standards, but it's what we've got. That's what they should be saying. You're supposed to be using the best available research, not perfect research anyway. So if that's the best they've got, then say so, but don't publish it as if it's good research. But this applies to nearly all of the studies. Even something as hard as physics, more than a few of those studies are bad, published and still bad. Psychology, they reckon you could throw out at least 50% of the research done in psychology, at least 50%, probably a lot higher than that. Now, physics has the advantage, as does chemistry and probably biology. They got the advantage, though, is that they will publish replication studies because they realize they're important. But medicine doesn't do it. You cannot publish studies that don't show a change. They won't publish those neither. So it's a bias on the part of the publishers, but it's not good for the profession.
Hey, Jim, so as a clinician, do we what do we do we rely more on specificity of the test or the sensitivity of the test?
Depends on what you're trying to show.
So let's say if the patient comes with the symptoms and we know then, and as soon as we ask, we say, oh, this one is hurting. So it's more sensitive for sure. But in other tests, if it's more, like, how do we know whether this test is like Hawkins test, for example?
Let's look at this. Let's take sharp Persa, all right? And the thing is very highly sensitive and highly specific. So it doesn't make much difference. But in that case, would you rather have high sensitivity and low specificity, or the other way around?
More specific.
Why? If it's not very sensitive, it means it's going to miss a lot. When it's positive, it's truly positive. But what are the ones that it's not showing because it's not sensitive enough? So you've got something important like that, where you're talking about a craniovertebral instability, it's probably more important that you can say, okay, you need more testing.
Yes.
Yeah, especially in our game. Like, really what we're looking for is a reason to refer them out. We're not looking at making specific diagnoses. Something like what we do a lot, biomechanical dysfunction, it would be nice if the tests were more specific. If you're looking at diagnostic accuracy, though, higher specificity is better than low specificity and high sensitivity. And these are not difficult to work out. If you work out likelihood ratios, the likelihood ratio is an indicator of diagnostic activity, accuracy rather. So you can work these out reasonably simply from the sensitivity and the specificity. So as soon as you do that, you'll find that when you're looking at high specificity tests, the likelihood ratio goes up higher than the other way around, much higher than the other way around. If you was to switch the sensitivity, and I haven't done this, but if you was to switch the sensitivity and specificity on the sharp Persa test, I'm going to bet you that test would probably go from 22, which is fairly high, really quite high, probably up to into the hundreds. It's not difficult to do, but I honestly can't be bothered. Look up likelihood ratios and play with them. You should be able to do these anyway, in all honesty, and you should be able to use Bayes' theorem, at least on the test that you're using a lot. You really should be able to. But on the test that you're not sure about, you need them there as well. And this is the problem. The schools teach this completely wrongly. Spin and snout is a really dumb way of doing this. It's much more complicated than that. What Bayes' theorem allows you to do is change the probability of that test working. So as you get more information coming, you add it on. So your first piece of information is probably about, I was looking at something on COVID recently, and they were saying that you look at these numbers, they're 98% positive on, sensitivity and specific. They said, but as soon as you have a high prevalence in the area, that likelihood ratio drops like a stone. And you're going to see many more false positives, simply because the prevalence goes up. Now, this is what Bayes is all about. It's coming out with an anterior odds before you do the test. You already know the probability this patient has it, based on prevalency usually. So based on that, you know the likelihood ratio from the sensitivity and specificity. So you simply multiply the prevalence, you convert it to odds, multiply the prevalence by the likelihood ratio, and that will give you the odds after the test is positive. And you can do it for negative tests as well. You get that's a positive likelihood ratio, negative likelihood ratio. It does much the same for a negative test, different formula, but it does the same sort of thing. So if they taught you this properly in school, this would be second nature to you. How good is this test based on what's the chance of this person having a positive test in the first place? But they don't do that. They teach easy crap, simple crap. And the worst of it is, you know, the absolute worst of this is, I can guarantee you that the majority of your teachers had PhDs. So these are supposedly all research specialists, and they teach research crappy. I can forgive the therapist not teaching it properly, but not a researcher. Yeah. There you go. Here's my bitch for the morning. Maybe the only one. I wouldn't guarantee you that. Hello, Kim. Okay, what else you got?
There was one of the questions I wasn't sure about actually on the prep exam.
I haven't got them in front of me. What was it?
It was number 33, which the following is of itself a contraindication to lumbar manip.
Yeah.
And at first I thought it was an instability above the level to be manipulated, but now I'm looking more at the moderate straight leg raise, moderate limited straight leg raise.
Give me the options.
Limited trunk flexion and moderate pain in the lower back and buttock.
That's two different ones or one?
Yeah. So
Okay.
you've got the raise, the limited trunk flexion, the
Okay.
moderate pain in the low back buttock, and then the fourth one is instability above the level to be manipulated.
Okay. So if you look at these, you can figure it out. Trunk flexion. How many patients do you manipulate with trunk flexion missing? All of them.
Yeah.
You don't care, do you? Providing there's nothing else going on, trunk flexion is an indication of a lot of things, but segmental dysfunction is one of them. Moderate pain is definitely an indication for manipulation, all things being equal. Instability, you're not going to go through it, so it doesn't really matter. And you can always lock in instability in the direction that it's not unstable in.
Yeah.
Yeah. I'll leave you one, straight leg raise. Now,
Okay.
that's in and of itself. Now, the straight leg raise may not be a contraindication. But of all those four, that's what your contraindication is.
I see.
Okay. So there's the reason you get distracted on these multiple choices, not just to distract you, but it's also to give you clues to the answer. And that's what that did. You can work your way through those options and pick the right one. There's only one there that stands out as a contraindication.
In what circumstance would a moderate limited straight leg raise be like not a concern?
Moderate. Well, you are moving other things than the straight leg raise. Now, if you're talking about a proper straight leg raise with neck flexion aggravating or relieving it and so on, then that's neuromeningeal. Is neuromeningeal necessarily, well, what can cause a straight leg raise, basically? This is moderate, so a disc could do it, but it's unlikely. So this could be a disc protrusion, which you potentially could manipulate. In itself, it's not necessarily a contraindication. I don't mind manipulating a small protrusion, so a straight leg raise wouldn't bother me too much based on that. This could also possibly be a lateral stenosis with an extension subluxation on it. So you've got things that will cause a positive straight. It could also be adherence from a previous disc herniation. So you've got scarring on it. So there's a number of things that could cause a straight leg raise, which in themselves wouldn't contraindicate manipulative technique.
Okay.
Yeah. You got more? Did you manage to get through all of those videos, or you're on your way through them on the questions?
Yeah.
I think they cover pretty much most, but I'm not stopping you from asking about them, all right? I'm not saying, okay, they've been done once, you don't have to ask me anymore. By all means, go through them, find out what there is, but I don't want to go through the whole lot when it's already been done.
Right.
Okay, so if they raise more questions than they settle, ask me, that's fine. I sent you the thing on the thoracic disc, didn't I? Did you get a look at it? Have a look at it, it's interesting. There is so little work done on that, it's unbelievable. Honestly, I don't think anybody really understands how they degenerate properly. I don't know that anybody understands how big the nucleus is compared to the rest of the disc. This hasn't been done because I think what everybody seems to be doing is saying, oh, it's like a lumbar disc. And you still got people saying that the lumbar disc is exactly the same as the cervical disc, and yet we know they're not. So to liken these two ends of the spine to each other is ridiculous. And what you do get a lot of is, oh, the thoracic disc is like the lumbar disc and like the cervical disc. Well, it can't be like both of them because they're completely dissimilar. So this is crap. They're basing this on what they've seen. I was asked a question on this. I presented this on a Zoom session to the American group. And the question I got was, what's the essential illness script of a thoracic disc herniation? And I said, I have no idea. I honestly don't think I've ever seen one, at least not knowingly. I don't know. So I said, the best I can do is what everybody else does and say, probably a thoracic disc herniation is going to look like a lumbar disc herniation. And they're variable as well. But I would assume that these things are going to look really bad. It gets really difficult to talk about these sensibly because the information is just not there. There was some interesting information on there that I didn't know. I know the size of the spinal canal in the thorax is relatively small. That's relative to the contents. So in the neck, the contents take up about 25% of the canal. There's the spinal cord takes about 25% of the spinal canal. The thorax, it's 40%. 40% of that is taken up by the spinal cord. So what it means is, and this is borne out by clinical impressions, is that thoracic disc herniations tend to produce more central problems, spinal cord problems, than it happens in the cervical or the lumbar spine, simply because it's so big. The other thing that affects it is there's dentate ligaments that hold the cord still in there, relatively still. But what they do is they hold it forwards. So if a disc hits it from the front, these ligaments stop it from displacing backwards as much as it does elsewhere. So it means that it can't accommodate that. So you've now got a small canal for its contents and an immobile spinal cord. And then on top of that, it's kyphotic, which increases the posterior direction of the disc herniation. So a lot of these, they're rare, but when they do happen, a lot of them go straight back into the spinal canal. Whereas in the lumbar spine and cervical spine, they tend not to do that. Even the cervical spine tends to go lateral when they go central. So everything's set up for the cord to be bothered by this disc herniation. The other thing that was interesting here is that only 60% of thoracic disc herniations have pain as a presenting symptom. And I don't go on past that point, but my guess is that what's showing is spinal cord issues. So it may be paresthesia, it may be weakness, it may be tripping, it may be a lot of things, but they're finding the disc herniation presumably after they've found evidence of a spinal cord. Then they'll do an MRI and see the disc herniation. So you don't even have the comfort of knowing that at least there's going to be pain with a disc herniation. 40% of them are not painful, and yet still produce neurological problems. It's really quite an interesting thing. If you're not looking at medscape.com, you should be. Okay. If you want a medical source of information, I strongly recommend that. All right. You've got to be acting like a doctor in your practice because you're seeing people off the street. This is not a physical therapy practice anymore. You are a primary care practitioner. So it means that people are going to come and see you with stuff that they have no idea they should be seeing you for. Yeah. And as much as I run the doctors down, I have no idea how much of a shield they were for us before. No idea at all. And you don't know neither. You can't say, well, I don't see any of this stuff because you actually don't know. You have no idea if you do or not. Whatever they're dying from isn't going to occur in the 3 to 6 weeks that you'll see them. So you have no idea. That's the source I would use. It's free. It's comprehensive, it's informative, and it's well written and well presented. Really look at it. And that's where I got this information from on the spinal cord, and it's all referenced. Not that there's many references in this case. Okay. I've just done a couple of videos. If you like, I'll go through the slides on this. This one's probably not going to interest you very much, but this one might do. Actually, I needed some share screen, didn't I? Sorry. All right, everybody see that okay? All right, what this is looking at is differential diagnosis for the all right, differential diagnosis, thoracic spine. Actually, sorry, let me get rid of these for you. All right, just look at that. I've broken this down into 2 parts, all right? But basically, these are the conditions I'm covering. And it's not that these are particularly common, it's more that it's really more that they are the ones that you're likely to see, as rare as they might be. They're not as rare as a lot of them are. So let me see. Get rid of that. And that. Is that legible to you, or is that too small?
It's okay.
I think if I do this, it's got to talk to you. Oh, there you go. No, I can't turn it off, sorry. Okay, so if we're looking at central and or bilateral pain. Now, central pain, the pain is actually in the middle of the back and it spreads out. Bilateral pain is, it may be associated with that and spread right out bilaterally, but what I'm really meaning here is it's not central pain, it's going bilaterally. Is that okay? At the same segment. So if we look at some of these things, if we go from left-hand side to the right-hand side, a gradual onset of moderate to severe pain. So this comes on gradually with neurological signs or symptoms. Now, the amount of pain you're going to get with this when you're getting a lot of neurological signs or symptoms and not much in the way of pain, the chances are this is a neurological condition rather than a locomotor system. Certainly if there's no pain at all, the neurological problem outweighs musculoskeletal one. We were talking about disc hernia, asymptomatic disc herniations compressing the cord. You're going to see all neurological stuff there and no locomotor stuff. So it's a fairly good indication when the neurological signs outweigh the somatic pain, then you know you've got a neurological problem on your hand. In this case, the range of motion is good, which is also suggesting that this is not a locomotor system problem. Dural tests are positive, maybe negative, depending on exactly what's being hit. The PAs over the spinal column are either negative or they're mild. You're looking at something weird. A tumor is the obvious one, particularly if this is an older patient. Okay. A gradual onset of moderate to severe pain, no neurological signs or symptoms. You've got moderate to severely limited range of movement. The PAs are very, very positive. You probably look, because this is central and bilateral, you're probably looking at a spondyloarthropathy. And the more severe the signs and symptoms are, the more an active arthritis is likely. So if this is arthrosis, you're not going to get an awful lot of severe pain, and your PAs won't be terribly dynamic. Through to a raging inflammatory condition, you're not going to be able to touch this patient. And it's going to be so bad, the chances are you won't see them anyway. But somewhere in that spectrum, you're looking at arthrosis to arthritis. Is that okay? Is there anything you need to ask there? Okay, so you've got central and or bilateral pain with neurological symptoms, a moderate aching somatic pain. Now, this is probably central or lateral stenosis, simply because you're seeing a reasonable amount of aching and it's moderate. So if you now do the PAs, you're expecting to see generalized stiffness. If this is a bilateral lateral stenosis, it may just be that segment that you're seeing the stiffness in. It may go up and down a bit, but that segment will be stiff. If it's central stenosis, then all of the area will be stiff as well. Also, where the symptoms are being felt, if they're being felt very segmentally, then it's going to be a lateral stenosis. If they're being felt more diffuse and basically you're looking at dural problems in. If you're actually seeing paresthesia, then you know the spinal cord is involved. Sudden onset of moderate pain, none to moderate or to severe trauma. So it could be either no trauma, moderate trauma, or severe trauma. And this simply depends on the severity of the underlying disease. The limited ranges are in all directions, particularly those movements that put pressure through the anterior column. So particularly flexion. When you bend backwards, you tend to shift the weight backwards onto the spinal joints and the pedicles. Most of the pathology occurs in the body. But all of the movements are going to be affected to some extent. You may well see spasm, and PAs are going to be very positive. Because if this is severe trauma, if this was actually a healthy bone fracture, you would have severe pain. But as you're getting moderate pain, you're looking at this probably being a pathological fracture. Now, in the vertebral body, that usually means osteomyelitis or a tumor again. Okay, so again, some of this is going to depend on age, but it really doesn't matter. You don't really care what this specific pathology is. You just want to get them out of your clinic. And this one should probably go to the ER. The tumor, you might be able to send back to the physician, but this one should almost certainly go back to the ER because this can displace and then you've got real problems on your hands. Or the patient does anyway. A sudden onset of severe pain, severe trauma, limited range of movement in all directions. Now you're looking at a healthy vertebral fracture. So they've done enough damage that this is going to be really quite painful for them. Unilateral pain, sudden onset of severe pain, moderate to severe trauma, limited range of movement in directions that stress the rib, which is mostly going to be rotation If it's side bending, for example, it's going to be positive when you side bend to that side. Flexion extension, probably not so much. It depends on the exact site and of where the fracture is. But the pain is going to be fairly local. It's going to be, if you palpate the rib, it's going to be tender, not the intercostal muscles now, although they might be if the rib's actually displaced in thorax, but the rib itself will be fractured. Now, with all that, you really shouldn't have to stress it, but if you're going to stress it, compress it. So get on the two ends on either side of the fracture and push the two sides together and try to compress the fracture if you're going to do that. This is going to be a healthy bone fracture of the rib. Sudden onset of moderate pain, no trauma or minor trauma, limited range of movement in flexion or extension, moderate responses to PAs and so on, particularly if this is episodic, although you might be seeing the first episode, segmental dysfunction. That's the only one that's straightforward in all of this, and we'll look at why in a second. Sudden onset of radicular coursalgia. There may have been an infection they can talk to you about in their youth. They're over 55 years of age. They've got good range of motion, but doesn't mean to say that range of motion is going to be pain-free. When you twist, in particular, you pull on the intercostal nerve, which pulls on the root, and if that's sensitive, you're going to set up the coursalgic pain. So, generally speaking, shingles is a continuous, constant pain that gets worse. Well, it's hard to say it's constant, but it's a high-level, continuous coursalgic pain that may be worse when you're with movement. You're looking at something like shingles. It could be a neuroma. So, but either way, it's not your problem. Get it out. Sudden onset of severe sharp pain and ache. Positive lancinating pain and paresthesia. All range of motion severely limited, obligate functional loss. Okay, I don't know what else this can be other than a disc herniation. But I'm prepared to accept, more than accept, that not all thoracic disc herniations are going to look like that. It's the same with the lumbar spine. A geriatric disc that isn't hydrated looks like severe central stenosis or severe lateral stenosis, I don't know exactly how it's called, but it looks like a severe stenotic problem. Whereas in fact, it's a cartilaginous disc herniation that can actually get under the end plate. So not everything looks the same in the thorax, because you simply don't know enough about this. The other thing with the thoracic disc is you don't get as much, or if at all elsewhere, is calcification of the disc. And they have no idea what that might do to symptoms at all. It's an issue when they're doing surgery on it, but what it's got to do as far as presentation is concerned, I don't know. But I think it's reasonable if you get that classic presentation of a disc herniation. You're probably right, it is a disc herniation. Trauma occurs mostly with young people in disc herniations, and non-trauma onsets with older people. Oh, by the way, this is something else that's interesting. The incidence of disc herniation, it shows you how much they don't know. The incidence of disc herniation, which you would think would be fairly standard, varies according to the imaging, obviously. So CT scanning is much less sensitive. MRIs are much more sensitive. So this is based on asymptomatic herniations. These people completely asymptomatic. With CTs, the number was up to very, very low, 11%. So 11% of the population, asymptomatic population, has a disc herniation. When you do MRI, that goes up to 40% of the population. Now, I know what they're doing because they do it all the bloody time, physicians, is they'll look at the body, they'll order an MRI, and whatever the MRI says is there is what their diagnosis becomes. So it means that there's probably a much higher rate of disc herniations diagnosed than actually exist symptomatically. Now, the interesting thing was on the incidence of these things. The incidence of disc herniation, symptomatic disc herniation, was put somewhere between 1 in 1,000 and 1 in 1 million. Now that's That's 1,000 times difference between the two numbers. How can they possibly think they understand this condition when you've got that disparity in the studies, saying 1 in 1,000 to 1 in 1,000,000? It's absolutely ridiculous. As far as neurological presentations are concerned, disc herniations, myelopathies and radiculopathies, it's believed to be about 1 in 1,000,000. Now that rules out the 1 in 1,000,000 incident rate for symptomatic disc herniations, because a lot of these don't produce radicular or neurological signs. But these are the numbers you're dealing with. Nobody, I don't think the research has been done properly. There's not enough of it being done. Oh, the other question I was asked was, the incidence of surgery is increasing. And somebody asked if that meant that they were being discovered more, possibly. And that's an issue with MRIs. If you're going to base all your surgery on MRIs, you're going to be doing stuff that is irrelevant, because the general population has disc herniations on MRI. 40% of them do anyway. But it may be that surgical technique has improved clinical diagnosis. Like, let's say you only had one person doing thoracic surgery 10 years ago, and that guy gets a reputation for doing it. He's then going to teach other people, who are going to teach other people, teach other people. So you'll get this basically exponential increase in the number of surgeons, and if you get an increase in the number of surgeons, you're going to get an increase in the number of surgeries. So it doesn't necessarily reflect a growing rate of improved diagnosis. It reflects a growing rate of improved surgical technique, I guess. Okay, so that's the thoracic disc in a nutshell. I don't think you're any better educated than you were before we did this. But I think you should be able, the main thing to take from this is, anytime somebody comes in with thoracic pain at all, do long track testing. All right. Ideally, what you would do is, any patient who comes into you, do long track testing. You know, in fact, do a neurological examination on them, because they ain't going to get one anywhere else. And maybe what the college and the school should be doing is exactly that. A new patient gets blood pressure automatically. No debate, no discussion. You do blood pressure, respiratory rates, you do a neurological exam, and that's it. As a routine baseline, that gets done. If you find any positives on any of those, you fire them back to the physician. I don't see anything wrong with teaching that. If you do this every day on every patient, you get damn good at it quick. But maybe to start doing oscillation as well. I don't know why they don't teach this stuff. I really don't. So there I am. I'm done.
I had a patient with thoracic pain.
Yeah.
This was I forget who it presented, but there was something off that made me think it was cardiac.
Yeah. Actually, that's my next video. It's a big problem in the thorax, is determining what's cardiac and what's not. And again, this is where you were shielded by physicians. If a patient goes into a doctor and says, I've got chest pain, they do it properly on the whole. So you're getting shielding there from, as opposed to somebody walking in off the street. That's my next video.
Okay.
You have to be careful. And I think you should be able to check for, I don't do it, but I don't practice now. But I think you should be able to check for cardiac murmurs and dysrhythmias and so on. Nobody else is doing it routinely. Why not? I've been to a couple of doctors now over the last 6 months or so, and neither of them have listened to my heart. Now, one of them ordered EKGs, but neither of them listened to my heart. So if they're not doing it, who's doing it? There are, actually, it's interesting. If you go on to look on the internet, and I did this a while back, you can, there's sound studies of this stuff, and they'll play the recording to you, ask you what you think it is, and then give you the answer to it. Like, this is heartbeats now. But they do the same with lungs and everything else. You can learn this stuff online now. And I really do think that with seeing patients on a primary care basis, we should be seeing them on a primary care basis. At least say, when was the last time you saw your doctor and had this? At least say that.
Yeah, I tried to explain to her that the pain could be cardiac and that she might want to see her doctor about it. But she didn't believe me, so I think she just kind of disregarded it.
Nobody wants to hear that.
No, it's true.
You know, there's half your trouble right there. You know, but you've done what you're supposed to do. It's not your job to hold their hands. Your job is to give them information, and their job is to act on it or not act on it. It's up to them. It's almost, you say, well, I hope she has a bleeding heart attack so I can be proved wrong.
Yeah. Actually, like when I suggest like maybe going to the ER, they're like, no, I don't want to do that, or this and that. And I'm like, okay, well, if it gets worse, you definitely have to go to the ER.
Yeah, well, at least go to your bloody doctor. If you're not going to do that, go and see your doctor.
I actually had
yeah, I mean, there are some signs that you can't get rid of, like dyspnea, like unusual dyspnea. You shouldn't be messing about with anterior chest pains, really, unless they've got actually tenderness over the costochondrium. There's not much else that's going to cause an anterior chest pain. Aching through the arm, left arm. If the neck's moving all right and everything else okay, send them out. I mean, I don't think this is really rocket science on our part. It's a matter of not being biased, not seeing what you want to see. And that's the biggest danger we have as a profession, is we don't expect to see this stuff, so we don't see it. It's confirmation bias. And again, I don't think the schools do enough to deal with this, particularly as now you're in primary care. What is it, 50% of your patients coming in off the streets? It's a lot of people that are not seeing the doctor. And they may not, I mean, I saw my doctor for the first time 3 weeks ago. I've been here for 3 months, or in Canada for 3 months. I saw him 3 weeks ago. And before that, my family doctor in Mexico, probably 2 years ago. I don't go to the doctors. I don't go unless there's a problem. Because they find stuff. That's the trouble, they find stuff. I don't go for an annual checkup, and I should do. Now, I'm like a lot of the population. Yeah. Anyway. That's my next video, I think. Okay, got anything else for me?
Jim, for the thoracic disc, the slides you were showing, is it included in the description of the link you sent us? Or you can...
Well, those flow charts?
Yeah, those flow charts.
No, they're mine. Okay. What I'll do is, I've got to send these videos out. I'm going to turn both of those PowerPoints, actually I have already done it, I'll turn them both into videos. So I'll put them onto YouTube so you can have them. And there's no reason why I can't send the group those slides.
Okay.
All right.
Okay.
So remember to do it, that's all. Okay. You good?
I have a question. I had a patient. This is very critical patient I've ever seen. Most critical, I would say. So this guy was hit by a car 4 weeks ago. Severe neck pain, severely restricted range of motion.
Yeah.
So pain was 8 or 9. That's what he said in terms of numbers. And he was taken to the hospital. He said all the tests were done, and I didn't have access to his Netcare, so I didn't know what tests were done. And he said they did all the tests. He wasn't admitted. They did all the tests. After 5 to 6 hours, he was sent back home that you're good to go, take Advil, this and that, and see your doctor if you need to. He saw his doctor after a few days. He still had the pain. He had occasional dizziness and headache. Headache was more posterior to more temporofrontal. And then doctor said, doctor, I don't know if doctor checked him properly. He said, doctor only saw him for 5 minutes, and I don't know if that was enough. And then he came to me, and then I checked. So his range of motion were limited. There was no increased headache. He already had headache. There was no increased headache with range of motion testing, and headache and dizziness were not coupled. Range of motion testing, headache and dizziness were all decoupled. He had tenderness, but he was say, don't touch it. I don't want you to touch it there because it's painful. So I was confused.
Is this central pain? Pain over spinal?
Yes, central pain. Pain. So I thought it could be a fracture.
Yeah.
So I said, I can't help you much. So I will say, go back to doctor again and check with him. And then he went to the doctor again. And he went to the doctor, and doctor said, ask your physio to do his job. And I said,
doctor.
And I said, that's my job. I found something fishy. I can treat you.
Yeah.
And he said, ask your physio to do the pain management. Your pain is more musculoskeletal. It will go away eventually. I don't see a big problem because I've seen all your tests. And I was like, did they do your CT scan? And this guy, he's a new immigrant. He just came to Canada 2 months ago. He doesn't know what's going on in the system here. He's like, I don't know what CT scan is. And I was like, okay. So then I don't know what to do, Jim. So in that case, what I did is like I treated his shoulder because that was hurting. So I put the heat and the tense there just to help that. And then I just saw him once, and then I said, okay, you better go see an emergency room doctor or someone who can listen to you and understand your concern. I've never seen this guy again. I don't know what happened. We tried calling him a couple times. We tried calling doctor's office, and he said the doctor's office said he never came back. So I'm very, I don't know what happened.
Concerned.
Very big concern. I don't know what was that.
Have you got an address?
And I did CN testing, cranial load testing. It was negative.
Yeah. Now, do you have a postal address for him?
I might. Yes, I do.
Drop him a note.
Oh yeah.
Yeah. I mean, the only other thing to do is go around and bang on the door. I mean, seriously, if he's not answering the phone and nobody's seen him.
I'm very concerned about this guy. Yeah, and he was like 19-year-old hit by a car, and definitely when you hit by a car.
Yeah, I mean, a month after the accident, he's still having severe pain. This isn't a simple inflammatory condition.
It is not.
So yeah, they should.
And thanks to your course, I figured out. Otherwise, I would have treated him normally like I do. But I realized that this is something serious I shouldn't be touching.
Yeah,
So
no, you're right. And if it turns out to be non-serious, you've still done your right job. They should have done a CT scan. The doctor's an idiot. You really don't want to deal with him.
But he was in ER room right after the injury, and the 911, the ambulance took him to the hospital. So I assume that they did they should have done the C-spine, and
I guarantee they did an X-ray. Guarantee they did an X-ray.
Oh.
But that doesn't mean everything.
He could have like C3 fracture or something where it doesn't cause all the, because he didn't have a lot of.
He could have a dense fracture. He could have any sort of fracture.
Oh, yeah.
But an immediate onset of central pain that way strongly suggests that something healthy is broken, either a bone, a ligament, or a muscle. Well, there's no central muscles you have to worry about, which means you're a ligament or a bone. You don't know which it is, so you do the appropriate study, which is a CT scan.
That's true.
It's bad medicine. Each family doctor should be ashamed of himself.
Of course.
No, you did the right thing.
Yeah.
Yeah.
I hope he comes back.
Even if they do all the tests, and even if he gets better in 3 days' time, completely better, all the pain's gone, and everything else, you still did the right thing.
Yeah.
Yeah. Not the outcome that matters; it's the process. Yeah.
No. Okay.
I have no problem with what you did there at all. Okay. Anything else?
I guess that's it.
Okay. Next Sunday, if I don't expect too many questions from the written questions, by all means bring them up. What I'll do is I'll prepare something to talk about here, maybe cardiac problems in the thorax. Okay. All right, guys. Nice
Hey.
chatting. I'll see you next Sunday, maybe.
Yeah.
Thanks, Jim.
By the way,
Thanks,
the
Jim.
sun's out here. Everything's nice and bright.
Lucky you.
Yes.
It's minus
It's-
20 here today.
Yeah, I got out
Not
just
only-
in time, I think.
Not only that, it's skating rink here in
Yeah,
Edmonton.
yeah, that's the thing, isn't it? Yeah, it's not, I don't mind the snow. It's the crap that follows it.
I know.
And the government's going to panic over Omicron as well, so I'm glad to be out of there.
Yeah, no kidding.
Yeah.
Mhm.
All right, guys, have a good winter.
Okay.
Thank you.
Thanks.
Thanks, everybody. Have a good weekend.
Bye.
See you guys.
Goodbye.